Welcome to this morning plenary session dedicated to the intersectionality in dementia, a topic which is very important to Alzheimer Europe. Alzheimer's disease and dementia affect individuals in different ways, and to make sure that our information, our services, as well as our research truly reaches all people with dementia and carers, we need to undertake major efforts to be more inclusive. I'm therefore delighted to open today's session, where we will be focusing on the importance of gender, ethnicity, and sexuality in dementia, as well as the experience and inclusion of people with dementia from the Down syndrome community. But before we start the presentations, I'm truly delighted to give a very special welcome to an early-stage researcher whose passion for inclusiveness and intersectionality made her undertake quite an amazing feat. Golnaz Atefi, are you here? Yeah. Golnaz is from the Maastricht University, and she decided to roller skate for dementia, and she aimed to break the world record of the longest distance skated by a woman during World Alzheimer's Month. She decided to roller skate from Maastricht to Geneva for the Alzheimer Europe conference, and on her way she met with researchers and Alzheimer's associations, including the Alzheimer Europe team in Luxembourg on World Alzheimer's Day. Throughout her journey, she highlighted the importance of inclusiveness in dementia care and research. It gives me great pleasure to welcome Golnaz here in the auditorium. Congratulations on beating the world record with your 1,026 kilometers on roller skates, and let's see a short video of a few highlights of your truly impressive journey. Please, the video.
Hello everyone. My name is Golnaz Atefi, and I am a dementia researcher. Since September 1st, I've skated over 1,000 kilometers across Europe to arrive here today and share something important with you. With advancement in digitalization, digital health technologies have the potential to transform care. These technologies can provide equitable and easy access to expert-level care, also for people with dementia and family caregivers, including those who are currently isolated. However, there's a significant challenge we face. When dementia-related data fail to represent diverse populations, any innovation or intervention developed may not be inclusive or effective for all those affected by dementia. I would like to raise awareness about this important issue. But I'm not doing it all alone. I am skating toward professionals, community members to collect their insights along the way. The theme of Alzheimer Europe conference this year is New Horizons, Innovating for Dementia.
And a very important part for our organization is also how we are reaching out to very often underrepresented community as well.
For sure, digitalizations and digital innovations will play a significant role. Hereby, I would like to share a few lessons learned of all the wisdom and insights I collected along the way from healthcare professionals, researchers, and community members. Moving forward, for the future of dementia care and research being more inclusive, are we considering improving dementia data representativeness, ensuring equitable access to digital health? Are we prioritizing inclusive dataset development? We should raise community awareness of their important role in research. Are we assessing dataset representativeness at all? We should implement policies that ensure funders prioritize inclusivity. Are we enhancing digital health literacy? Are we communicating results of our research transparently? Moving forward, we should engage stakeholders in addressing disparities. Are we considering ethical implications guiding AI in healthcare? We should facilitate international data sharing and intercultural collaborations. Are we making digital health accessible for older adults? How we would want to evaluate effectiveness across population? And finally, we should establish mechanisms for ongoing community involvement. Now, it's time to act. By focusing on inclusivity, we can close the health gap and ensure that no one is left behind in the digital era.
So congratulations, Golnaz, for your record, and thank you so much for campaigning for inclusiveness. And now let us move to our first speaker, Antonella Santuccioni-Ciada. It will talk us about the importance of gender in dementia research. Dr. Antonella is an ethical doctor renowned for her expertise in neuroscience and psychiatry, as well as her leadership in organization management, research, and clinical development. She is the founder and pro bono CEO of the Women's Brain Foundation, a non-profit organization dedicated to using precision medicine to explore the impact of sex and gender on mental and brain diseases. In addition to her whole Women's Brain Foundation, Dr. Ciada serves as the Vice President and the Board Member of EU Research, a Swiss agency that supports research and innovation activities across Europe. Dr. Antonella, please, the floor is yours.
So good morning, everybody, and thank you for being here this morning. I am absolutely delighted to have a woman in the room that broke a world record, and I think it's up to us women in this room to change the status quo. What I'm going to talk to you about this morning, it is what we as an organization started in 2017, when we were the first to publish with an article that was on Nature Neurology Review that Alzheimer was female. And I tell you, we were at the beginning not really taken that seriously because it was not considered as an issue yet. Nevertheless, our science since then has proved that indeed both sex and gender have a crucial role in Alzheimer's disease, and I wish I could say only Alzheimer's disease, but actually sex and gender has an impact in the entire medical ecosystem, and above all on neurological conditions and mental diseases. So we talk about depression, multiple sclerosis, migraine, you name it, you have it. Today it's about Alzheimer. Before we go into the topic of the science that I will give you a glimpse of, few words about who we are. We are a newly established foundation, the Women's Brain Foundation. We used to be an association, and what we have done over the last 7 years, it is to come up with a huge community of followers that embrace the patient voice, it embraces the scientists, it embraces the medical doctors, the communication experts, the journalists, and the entire ecosystem, trying to change the medical field into sex and gender precision medicine. We have published more than 100 of peer-reviewed scientific articles on the topic of sex and gender medicine, embracing cardiovascular, COVID, and all those brain and mental conditions I have mentioned. And of course, we contributed to impactful policy reports that finally, in 2024, were capable of bringing the change that you are all witnessing around the board. We finally have organizations like McKinsey, like Kearney, pharmaceutical industry, scientists, foundations like the Melinda Gates that are picking up the topic of sex and gender in medicine. We can say we have been pioneering. Now, when it's about Alzheimer, this is a study that we did a couple of years ago that says, of course, it's about numbers. 2/3 of patients are women, and they have, as women, a twofold higher lifetime risk of developing Alzheimer's disease. So it's not about the classical comment I hear from even Alzheimer experts saying, oh, but it's because women live longer. No, it's not because we live those few years longer. Actually, we live longer, but we live even worse with more comorbidities and pathologies than men. It's about really having a specific risk as a woman of developing Alzheimer more than a man would have. This is a study that looks at the population worldwide that is having a beta pathology in the brain, and maybe they don't even know about it. This is a health modeling we have done with our colleague Gustafsson, and we can see that when it's about men and women, we have that in the full continuum of Alzheimer's disease, the whole spectrum, women are almost double than men. It's, of course, not only about numbers, it's also about specific risk factors that women do have. For instance, if a woman has an ApoE allele mutation and will have a higher likelihood of having higher tau pathology, and she will also have, therefore, an increased risk of progressing faster towards dementia. We have just the new release of the work done by the Lancet Commission, updated this year, where we have that there are specific risk factors that can be controlled for, reducing therefore the likelihood of dementia, that are listed here, for instance. And we know that sex and gender have a strong impact on most of them. Let's take, for example, education. Education, we know it is a preventative factor for not having dementia when we are older, and we know that women worldwide are less educated, above all the old generation. It might change in the future, we don't have data yet, and my question is also how long do we keep on educating women, because often we have the phenomenon that women hit university but then they get drained for their role as caregivers or motherhood. We know, for example, depression. Depression is 80% female. Depression is a specific risk factor for having dementia. We mentioned, for example, social isolation. Being a caregiver poses a person to be socially isolated and therefore to a higher risk of having dementia and depression. So it's like, a vicious circle that represents a specific risk for the female population of having dementia. We also know that, as I mentioned earlier, that in the female population, the progression of the disease is faster than in men. Cognitive decline goes much, much faster. And it's also about the subjective cognitive decline. Subjective cognitive decline has higher significant rates in women with subjective cognitive decline. There is a faster rate of decline than in the male population. We mentioned digital health. This was in the presentation, the video we heard before. One study, for example, that has been published at the beginning of the year shows that digital biomarkers are able to depict the symptoms of subjective cognitive decline only in the female population and not in the male population, versus the doctor who cannot objectify these symptoms of subjective cognitive decline, meaning that digital biomarkers are more accurate than us as humans to really measure this subjective cognitive decline that women often report and that cannot get documented by the current scales we use. We speak about tau already. We said that tau burden, it is higher in the female population for same level of amyloid pathology in specific regions of the brain, which is a cause, of course, for the accelerated cognitive decline. We have also one of the latest publications a couple of weeks ago that shows that was found an X chromosome mutated loci that finally gets associated with a higher risk of Alzheimer in women. So things are finally changing, but why does it have an impact? I mean, this is absolutely fundamental in the way we do design clinical trials and understand the effect of our drugs. Menopause, it's also a risk factor for Alzheimer's disease, and we know that high level of estrogen are protective, for instance, of what we know to be genomic instability. We also know that estrogen are protective on the neurons in our brain, and we know, for instance, that early menopause represent a specific risk of having dementia later on in life. There are several studies on this. What we still don't know, in my opinion, it is the effect of hormonal replacement treatment. There are studies that says that it will be beneficial, studies that says the opposite, and it's true also for pregnancies. There were a wave of literature a couple of years ago counting number of pregnancies and miscarriages and making a correlation with a specific risk in women for Alzheimer's disease. But the science is not yet clear, unfortunately. We have to research a lot. Certainly, we know that there are profound sex and gender differences in mechanisms associated with neurodegeneration. This is about the microglial activity of cells, microglial cells in our brain. It is about the capacity of eating up the toxic stuff that are deposited in the brain, like neurotoxic proteins. It's even having an impact on the microbiome, and there is a strong connection, as we know, between the gut, the brain, and all the neuroinflammation and neurodegeneration around it. Now, I think I have give you a flavor of how vast and big the problem is and how much we have to research. Speaking still about menopause, what we know is that when we get hit by menopause, women have a higher deposition of tau than men would have. So these are all evidence that needs to be taken into account when we do clinical trial and drug development. To the point that, when we look at the effect of these newly approved drugs, from aducanumab that we know got discontinued in production, to lecanemab, to even gantenerumab that wasn't approved but showed the same trend, we know that those drugs seems to work better in the male population. And this is, of course, a matter of concern. On the other hand, maybe the reason is as trivial as it can be. What about a specific adjustment of the dosage for women? Maybe women need higher dose than men. Did we take this into account when we did the trials? No. Did we take this into account when we did preclinical science? No. And I can say that because I was in a lab, I was working as a regulator, I was seeing patients. That was not what I was doing, and this is not what I was taught to be doing. And when I posed the questions, by the way, of making experiments for behavior, not mixing the mice, male and female mice, on the Y maze to test cognition, because I said to my professor, well, it's like if I take my teenager and I will let him do a mathematical test with girls in a bikini, or if I take a girl and I let beautiful boys walking over, they will be completely distracted. I was told you are wrong. So this was around 12 years ago. The drugs that we put on the market were developed back then. So, this is a systematic problem that starts in vitro, and we have science and publications that claims that even in vitro system, we should consider the sex of the cells. I was speaking with a biotech that is working with us, and she was like, do you know how difficult it is to find female cells? I leave you with these thoughts. Now, this is what we're going to publish in a couple of weeks from now. It shows, for example, that the CDR sum of boxes, which we know it's used to measure the effect of drugs that we presented earlier, it's biased based on the sex of the person taking the assessment, whether it is a man or a woman, and women score the test higher. The bias is also in the grade of relationship that exists between the person assessing the patients and the patient himself, being spouse, wife, kids, or just a nurse. So I'm giving you examples of how the whole bias, it's embedded from the very beginning till the very end. And maybe it's really these very simple things like, who is taking the test that impact the outcome of an entire clinical trial that has cost lives, has costed time and billions. So I think we really have to change. I still believe that digital biomarkers are going to be the solution because that's about objective measures. Of course, we go to the data set and the inclusivity. When we speak about the gender problem, then I think, again, Alzheimer is female because it's about women being the majority of those who take care of Alzheimer patients, either paid or not paid, meaning relatives or nurses, for example. And of course, this is true for all other diseases, but even in Alzheimer. And as I mentioned earlier, being a caregiver poses to a higher risk of social isolation, depression, and this is a specific risk then to have dementia when this lady will get older. This is a data that upsets me tremendously, and it speaks again for the profound bias we have worldwide when we speak about women and men and how we manage patients. These are data from the OECD, and we see, of course, that women are the majority of patients with dementia in most of the OECD countries that share the data. But what we also see is that women are most likely, with a 31% higher probability of being prescribed with antipsychotic. I have prescribed myself antipsychotic. They treat symptoms, they shut down the brain, and please, you can quote me with that. I don't think that they are a solution. They're just a way to pacify our patients. And they also have tremendous side effects. So basically, women get institutionalized more, meaning they end up in elderly homes more than men, because they are widow, because they are poorer, because they are just women. And then they even got antipsychotic more prescribed, together with painkillers, sleeping pills. You can go to the statistics of each single country, and you will find the same phenomenon across Europe, across the world. So this is what I don't like, this is what I want to change, this is what we are changing as an organization. How? This is, for example, one of our initiatives. We are organizing, together with Medscape, a forum that will teach healthcare professionals about sex and gender differences across brain and mental condition, of course also Alzheimer. This is an activity that requires support. Of course it's complex and it requires a lot of resources to organize such forum that will bring the knowledge hopefully to 20 million healthcare professionals. This is what Medscape guarantees, 20 million healthcare professionals that will be hopefully trained to these differences, because we can talk about it as much as we want, but if it's not about the doctor that sees the lady or the man in the praxis, things won't change. We presented 2 days ago the work that we did also on patient journey, and we can clearly see that men and women have a completely different patient journey. Women got a higher prescription of antidepressant through the whole medical history. Women will see more a general practitioner, while the man sees more often a specialist, so there are really things to be changed. This is the science we do. Please keep in mind that we are an organization that it is self-sustained, that it is highly productive. It has a collective of 60+ scientists around the world that publish together with us, and we are very prolific. We have at the moment, I think, already, this is not accurate, I think 6 publications since the beginning of the year. We have all those ones you see submitted. We are doing a publication with McKinsey to speak about, you might have heard this 1 trillion return investment opportunity that they launched at the World Economic Forum. We went to them and said, okay, let me know out of this 1 trillion return of investment opportunity for women's health research, how much it goes to the brain. 25% of 1 trillion in women's health goes to the brain of women, just to let you know how big is this gap. And I want to conclude with what we are also doing, which is an awareness campaign that it's also aim to raise the funds. We were willing to share with you some postcards also to finance our research. Unfortunately, the postcard got lost in the building, but please go on our website and support our research, independent research, self-financed. So women don't deserve this majority. I think you all agree with me. I see a majority of women. I'm not surprised. These kind of topics don't interest the male population. Sorry, I'm not a feminist. I'm mother of 2 boys. I'm married with a wonderful man, but it's what we observe empirically. Anytime that there are female topic related, the room is only populated with women. And that's also what I want to change. Women don't deserve this majority because we don't have to be the majority of the caregiving. We don't have to be the majority of the patients with Alzheimer, with depression, with multiple sclerosis, with anxiety. I can go on, unfortunately, for much longer. And I conclude with this. I worked across pharmaceutical industry, regulatory agency, policymakers. I can say that neuroscience and psychiatry and neurology are the branch of medicine that have been the most unserved as compared to oncology, as compared to infectious diseases, as compared to all the rest. We know that funds don't get fueled. We know that discoveries are difficult to accomplish and drugs are super complicated to bring on the market. Let's not talk about what happened with those Alzheimer drugs. I think that one of the reasons why this is so, it's because majority of the patients for neurological and psychiatric conditions are women. This is part of the problem. So I don't think that there is enough attention. People do not care. And that was one of the reasons why this field of research, in my opinion, did not advance to the same speed that others disease area managed to accomplish. And with this, I close. I encourage you to support us. I encourage you to think what you do in your labs, in your clinical trials, in your PK, PD studies, in the dosage of anything you want to measure. And yeah, let's change together the big gap that exists in the health system. Thank you.
Next speaker, Una Nielsen from Denmark, who will talk us about reaching out to and including minority ethnic groups in dementia research. Please.
So good morning, everybody, and thank you for being here so early in the morning on the last day of the conference. So I'll be talking about reaching out to and including minority ethnic groups in dementia research, which is something we have been doing in the Danish Dementia Research Center for the last 15 years or so. So we've been doing numerous studies along the healthcare pathway, targeting minority ethnic groups, using many different methodologies, developing new tools to assess cognition, psychosocial interventions, epidemiology, and so on. But today I'll mainly be talking about a study that we are concluding at the moment, looking at timely assessment of dementia in minority ethnic groups, looking mainly at assessment methods. So as we have heard in some of the previous sessions at this conference, there is an increasing number of people from minority ethnic groups with dementia. This is mainly due to the demographic shift that we see in most European countries with larger and larger older populations. And this also includes the minority ethnic groups. So as in the UK, where we see a 7-fold increase in the expected number of people with dementia in minority ethnic groups during 2 or 3 decades, we made the same prognosis in Denmark, where I'm from, and we see exactly the same numbers, a 7-fold increase, and that's quite dramatic. And also means that our healthcare services need to take this into account when preparing for the future. But despite the apparent need for timely diagnosis and care in minority ethnic groups, several studies find a lower diagnostic rate and service use in minority groups compared to the majority populations, indicating that there are significant barriers in access to care. So among those barriers, we see that there's a general lack of diagnostic tools catering to the specific needs of minority ethnic groups. It may be in terms of cultural differences or diversity and language diversity. And importantly, this may impact on both initial help seeking due to prior experiences with meeting the healthcare services, being assessed with tools that might not take your educational background into account, your language capacity into account, and so on. And also, it might end up not resulting in a correct diagnosis. Importantly, what I found in some of my earlier studies was an indication that especially middle-aged females or women from minority ethnic groups were at higher risk of being misdiagnosed with an affective disorder when attending a memory service. So, in the timing study, we aim to improve timely diagnosis of dementia in people from minority ethnic groups. And this was an international collaborative study supported by the Danish Velux Foundation. They're producing windows and apparently earn a lot of money on doing that, so they can support research. And our specific aims in this study were to identify enduring challenges in cross-cultural dementia diagnostics across Europe to inform recommendations for clinical practice. Also, in Denmark, we developed some new culture-sensitive dementia case-finding tools for general practice, both primary care physicians and primary care nurses, that we wanted to validate in a multicultural population. So importantly, in this study, reaching out to and including minority ethnic groups was central to all of the research questions. So we could not do any of the studies without involving participants from minority ethnic groups. So in order to do these studies, we established an international consortium across Europe with many different partners, including Alzheimer Europe and the European Alzheimer's Disease Consortium, and several university medical clinics in both Denmark, Italy, Spain, the Netherlands, France, and the UK. To answer the first question, the first aim, we did an online survey in the European Alzheimer's Disease Consortium to try to understand some of the barriers that were faced by highly specialized clinicians in highly specialized dementia clinics to get an idea of the field across Europe. And in Study B, we validated 2 novel brief case-finding tools across the different countries in both the majority and minority populations. And I'll try to explain the studies, some of the findings, and how we included minority ethnic groups in the studies. So first, the first study, which was the online survey in the EADC, this was actually a follow-up survey of a survey we did 14 years ago. When I first started doing research within this field, one of the first things I did was to do a survey in the EADC about the challenges in cross-cultural dementia diagnostics. And quite interesting, at that time, doing surveys 14 years ago, I sent out personal letters to all members of EADC with a stamped return envelope or a fax number. Of course, that's much easier today with online surveys. So a lot has happened in terms of digital solutions, not only in dementia, but also in our everyday lives. But in this follow-up surveys, we had 33 EAG centers responding from 15 countries about their perceived barriers and their experiences of doing diagnosis of dementia in patients from minority ethnic groups. And what was new in this survey, the second survey, was that we included carers and people with dementia from minority ethnic groups to support and better understand some of the findings of the survey. So we did semi-structured online individual interviews with 2 carers from the Indian Sikh and Black Caribbean communities in the UK, and a person with dementia from the Black Caribbean community in the UK as well. And that was conducted by Alzheimer Europe within the framework of public involvement. And overall, the result from the survey, we could see that there has been a shift across Europe with clinicians perceiving to have a higher clinical expertise in assessing patients with diverse backgrounds. And this has come along alongside a reported increase in referrals of patients from minority ethnic groups. A bit surprising to me when I did the survey 14 years ago, many of the clinics reported that they did not see any patients at all from minority ethnic backgrounds. And some of them even considered that's quite strange because our catchment area has 30% minority ethnic populations, so why do we don't see the patients? But that has changed. So that's also the picture in many memory clinics across Europe now, that we see more and more patients from culturally and linguistically and educationally diverse backgrounds. That being said, there's also still a continued need to implement more effective strategies for bypassing some of the cultural and linguistic barriers. Because what we found in the survey, and this might be a bit hard to see, but we collected data on indicators of culture-sensitive services, which included having knowledge about services in the area that had a specific service for minority ethnic groups, a dementia service, that is. And here we actually saw a significant increase, which I think is mainly due to the fact that, for instance, in the Netherlands, there are now specialized multicultural memory clinics in the larger cities. The same is true for Paris and possibly also other countries. So there's been a need to establish specific services for minority ethnic groups in some countries. However, across the many different indicators, which also includes having access to professional interpreters, using cross-culturally validated screening tests for cognition, depression, and so on, none of the indicators passed 40% across the countries. So although there's been some increases, especially in terms of using cross-culturally validated cognitive tests, still less than 50% of the centers reported having access to these tools or living up to these indicators. So to support some of these findings, we asked for input from people living with dementia and minority ethnic groups to get their views on some of these issues. And mainly we discussed the use of family members as interpreters in contrast to using formal or professional interpreters. And these are just some of the many, many statements that we got from both the person living with dementia and family carers, that some of the issues of using family members as interpreters, although they are readily available in many clinical settings, speak the right language, speak the right dialect, knows the patient, there's already trust, which is all good, there are also some limitations. For instance, one of the carers said that with the family, they'll be rather emotional, might not understand what's going on, get confused themselves, or get upset for the relative. So I think that's really important, that when you have a family member or a carer sitting in as an informant at a dementia assessment, that's what they should be. That should be a family member and an informant, and not an interpreter. That can be quite stressful, and is actually a professional task. Also, as it's stated here, there's the issue of empathy, as your relative, that is the person with dementia, may use strategies to hide the difficulties they're having, and you want to respect that. So that also means that sometimes you risk that family members may not interpret what's being said, or trying to hide what's actually being said, to protect, you could say, the person with dementia. So it might be biased. So what we also did was we tried to validate some novel case-finding tools. That's a basic and basic Q. I'll return to them in a little while. And in this study, we managed to include almost 400 memory clinic patients and around 80 cognitive intact controls, of which about a third had immigrant status. So we've been discussing that in previous sessions. Who are the minority ethnic groups or populations as a group? Is it one group? No, it's not. Immigrants is another term. Who are they? Many different people, many different countries of origin, and so on. So in this particular study, this is illustrated quite well because the participants originated from 49 different countries and spoke about 41 different languages. So that also indicates that the clinical reality in Europe in terms of cultural diversity is that it's immense. So catering to all the specific language needs, all the specific cultural differences when developing cognitive tools, for instance, would be impossible if we aimed at having cognitive tools for specific groups of languages or cultures. That's simply impossible. So a very important part of our research has been to try to develop tools that can be used across cultures, languages, and educational backgrounds. Because in everyday practice, having 49 different tools in your drawer as a clinician, that's not feasible. But if you have one or two alternatives to what you usually do, that might be implemented and actually used in clinical practice. So in this study, in order to include all the participants, we collaborated across 8 sites, across several European countries, mainly larger cities, and importantly, all of the members in the study are part of ECRON, or the European Consortium on Cross-Cultural Neuropsychology, that was established back in 2009. At that time, we were 5 people who thought we needed this in Europe to try to combine forces, researchers doing cross-cultural research and cognitive assessment, and today we are around 40 members from around Europe and also outside of Europe collaborating on these issues. So all the members had a specific interest and expertise within the area. The sites that were most successful in recruiting patients and healthy participants from minority ethnic groups were the clinics in Copenhagen and Madrid, mainly due to the fact that the clinics had a very large uptake of patients from minority ethnic groups. So that was part of everyday clinical practice, that we saw a lot of patients with diverse backgrounds. And then we had clinics in Paris and in Rotterdam that were specialized multicultural memory clinics. So most of the patients had minority ethnic backgrounds. So that's quite important for inclusion, that you actually have the referrals. So we did not have to look for the patients, they came to us. Also, importantly, for recruiting healthy, controlled participants, in both Rotterdam and Copenhagen, we employed bilingual, bicultural research assistants who could visit the families or visit the participants and do the assessments in their own homes in the same language, with the same cultural background. And that's been quite important in a lot of my research, at least, having bilingual, bicultural researchers or research assistants helping establish trust, recruit, and assess participants. So, briefly, the basic and basic Q, that is the brief assessment of impaired cognition and the brief assessment of impaired cognition questionnaire, are 2 brief case-finding tools that can be applied in less than 5 minutes. And they were developed by the Danish Dementia Research Center back in 2019 and 20 by Kasper Jørgensen and myself. And it was funded by the Danish Ministry of Health to try to develop new tools for general practice that were more effective than the ones we have used previously. That is the mini-mental state examination and the clock drawing test. So what's novel in these tools is that they include 3 different aspects. So they have formal cognitive assessment, but also include self-report and informant report. So that's really important, not only because it's much better to ask the family caregivers about cognitive impairment than doing a cognitive test in many situations. They know, actually. And also it turns out to be an instrument that's quite inclusive, but because you have to ask the patient about their opinion about their cognitive function, and you also have to ask the caregivers, if they're present, about their opinion about cognitive functioning. So it's quite inclusive. And also in our original studies, it actually also has higher diagnostic accuracy than the mini-mental state examination, although it takes just 5 minutes. And for the basic questionnaire, that was developed due to feedback from primary care nurses who said, well, when we enter the homes of people with suspected dementia, we do not want to do a formal cognitive assessment. That can be quite confrontational, and that will affect our collaboration with the families in the future. So we would really like more a questionnaire of items that you can just include in everyday conversation. So for this specific tool, we took out formal cognitive assessment and included some questions about orientation in time and age, which can be embedded in an everyday conversation, more or less. And also, it still includes the same self-report and informant report measures.
Please,
yes.
Ready to conclude?
I will be ready to conclude. Okay. So, very briefly, these measures, we validated them in a multicultural population across Europe. In regression analysis, we found that both the basic and the basic Q were completely unaffected by sex, education, immigrant status, and whether it was this assessment was performed in the first or second language. We also found that the measure had very high diagnostic accuracy for cognitive impairment, and that the diagnostic accuracy was not different between European native-born and immigrant participants. So it appears that these two very brief case-finding instruments are truly cross-cultural and very little affected by socio-cultural variables. And very briefly, what has been successful in the studies I've done and what has been less successful, I think I'll just look at what has been successful in terms of recruiting participants from minority ethnic groups. Certainly, involving bilingual and bicultural researchers has been key, for my research at least. Also, collaborating with specialized clinics or clinics with high expertise in cross-cultural assessment and diagnostics, and using existing networks, both professional and social networks, from bilingual, bicultural colleagues or research assistants to recruit. And of course, try to bypass language barriers by providing interpreters, offering home visits, and not expecting people to come to the clinic because traveling might be difficult, especially for older people from minority ethnic groups who might need to rely on adult children for being transported, and so on. So very briefly, I'll wrap up. Some of my key messages from this talk is that I don't think minority ethnic groups should be considered hard to reach in dementia research, but they do require a different mindset and approach from the researcher. So importantly, the practices that we usually use to recruit and involve research participants very often do not consider the diverse needs of minority ethnic groups, especially language. So many studies, you see an inclusion criterion is that the participants do not speak the majority language. Exclusion. So of course, in most research, we do not include participants from minority ethnic groups. So I think my message would be that researchers should be creative and flexible in their recruitment strategies and consider various strategies before even starting the project when doing research in diverse communities. Thank you.
Thank you very much for your excellent presentation. And now let us move to our next speaker. Sorry, my glasses. Our next speaker is John Angel Bones from the United Kingdom, and he will speak us about acquiring up dementia care, the next steps. John is a dedicated PhD researcher in dementia studies at University of Stirling, focusing on the unique experiences of queer men living with dementia. His research was ignited by a deeply personal experience where he had to support a gay man with dementia who felt compelled to return to the closet. John is also involved in a research project exploring the needs of the LGBT community and those living with dementia. With 12 years of hands-on experience working in dementia care homes across South Wales, John brings a compassionate and insightful perspective to his work. He is a committed member of the LGBT Dementia Advisory Group, advocating for inclusive and sensitive care for LGBT individuals. John's work is driven by a passion for ensuring that queer people with dementia can live authentically without fear or stigma. Please, John, we are very curious to listen to you.
Thank you very much. So I'm just going to be talking about an article which I co-authored with Mike Parrish, who is also a member of the LGBTQ plus Dementia Advisory Group, and we did call it Queering Up Dementia, the Next Steps. So I'm a PhD researcher with the University of Stirling, and I'm also recently become a director of the LGBTQ plus Dementia Advisory Group. And Mike Parrish was one of the founding members of the group, and he's also a former unpaid carer for his husband. But so today the aim really is to raise awareness and promote inclusive dementia care for LGBTQ plus individuals living with dementia by addressing unique challenges and sharing best practice. And we're going to, like I said, dispel myths and misconceptions and promote culturally competent training, encouraging policy and systematic change. So, Bringing Out Dementia was the biggest single project in the United Kingdom, funded by the Alzheimer Society. And when that project was running, they estimated that there was about 68,000 LGBTQ plus individuals living with dementia in the UK. And as you can see from the map, there's also a considerable local and regional differences in the population numbers of LGBTQ plus people in England, Wales and across the UK. Because in the 80s and 90s, a lot of the community used to move to places like London, Manchester, because the communities were more accepting there. But the LGBTQ plus Dementia Advisory Group reports that there is no accurate number of LGBTQ plus people living with dementia in the UK, and that any reported figures are likely to be underestimated. And this is because sexual orientation and gender identity are personal and complex aspects of individual lives, and not everyone feels comfortable or willing to disclose this information in the surveys or the census. And in the United Kingdom recently, they included sexuality and gender identity as a question, but it was also a voluntary question. And a lot of the time, people just didn't want to answer. So, some of the myths and misconceptions. So, there is a common myth that LGBTQ plus individuals are either immune or less susceptible to dementia, and that LGBTQ plus individuals without families have adequate care networks in place, and also identity or sexual orientation becomes irrelevant in dementia care. And when I was practicing myself, I did see that happen quite a while. People's identity, they withdrew in themselves. So what does the research say? So there's an increased vulnerability, and the research does indicate that LGBTQ plus individuals are at a higher risk to social isolation, mental health issues, substance misuse. So that all this can complicate dementia care. There's also discrimination from services themselves, and studies show that many LGBTQ plus individuals do report discrimination in healthcare settings or dementia care settings, and that leads to a reluctance seeking help or accessing the memory services. And there was recently a film launched in the UK called Ted and Noel, and it's about a true story about a gay couple. One of them was living in a care home, who was actually being homophobically abused by the staff, and that is in 2021, 2022. So it's still happening across the board. And then, yeah, research also emphasises the importance of recognising the LGBTQ plus identities in care. And basically, if you recognise those identities, affirming care does improve the dignity and quality of life. Evidence also supports that there is a need for inclusive training, and dementia care training providers should be delivering training on LGBTQ plus issues or history, and this can also significantly enhance the quality of care for LGBTQ plus people living with dementia. And I feel it should be mandatory training from once you start, because I think in Wales you've got to do a 6-month induction training programme, and according to the Welsh Government, that's part of the training, nothing in the resources. And then, yeah, and also research highlights that there are strong community connections, and also LGBTQ plus people normally have a chosen family for support, and which mitigates the risks and improve outcomes for LGBTQ plus individuals facing dementia. And from some of the cultural experiences, LGBTQ plus individuals, like, sorry, I lost my place a second. Yeah, so basically, dementia doesn't discriminate. So, like I said in the last slide, LGBTQ plus individuals are more vulnerable due to the higher risks, like the socialization, the anxiety, especially as they're getting older. So this does make dementia care more challenging. And also, LGBTQ plus identity continues to be important for a person's dignity and well-being, and that sense of self throughout all stages of their life, and that should be recognised. But what can happen when it goes wrong? So one thing is, a lot of them, from my experience of working in dementia care, I'm a gay man myself. When I worked in the sector for 12 years, there was no training around, even though I knew like from personal experience, no training, no support, and anything like that. And from there, it can lead to an unintentional or intentional discrimination or insensitivity. And the one care home I worked in, and this has got me passionate about what I do, I think I was in a year into working in the care home, and a guy with dementia came out to me. I had a partner, and I think after 2 weeks of me being there, he knew I was gay. He wanted me to keep it a secret, not tell anyone. And over the time, which I'm completely against doing, but I supported him with what he wanted to do. And yeah, and as the disease progressed as well, he forgot who his partner was, and it was really distressing and upsetting for everyone involved. So this is why I'm quite passionate about what I do as well. Yeah, and then ignoring the chosen family can result in socialization and inadequate support for LGBTQ plus individuals. And I know, especially in the UK, up until recently, life partners or even friends who knew the person quite well weren't involved in that person's care, and family members who they might have not seen for 30, 40 years are coming in as next of kin, and they didn't want them to know they were gay as the disease progressed. And yeah, and also if there's a failure to use the preferred names and pronouns, this can also cause distress and a sense of invalidation. So, for example, I always walk around with a pronoun badge on me. So, and like I know there's some people do think like having pronouns on the badges, for example, but you can only have so much space on these, so you can get these easily online. So there are ways around it. And also about the stereotyping and assumptions, and this does happen still today. Anyone who goes into a care home, the automatic thought is that they're straight, and a female friend, if it might be their wife and stuff like that, and that's still happening today. And when I go out and visit some care homes back where I live, I do challenge that a lot. And yeah, and then basically by failing to create safe spaces in services, it's not fostering that inclusive environment, and that could discourage LGBTQ plus individuals from being open about their identities, their needs to people, and that can negatively impact on their care experience. So some best practice recommendations. So I mentioned about fostering inclusive environments, and so like you can ensure there's visible signs of LGBT plus inclusion throughout services, either like in your marketing materials, service newsletters, which goes out to key stakeholders, family members, and the University of Kent have just launched, it's called the Circle Project, and it's a co-produced piece of work that helps assist care homes to be more inclusive as well. And they also recognise that there is a chosen family members instead of family members, because a lot of the time, majority of LGBTQ plus people might not get on with their family members. So speak to their partners about their life history, get to know them that way, because they'll know more about that person. And also try and use inclusive language, and if appropriate, incorporate gender-neutral language and allow self-identification. One example you can do that is in any forms you use, and if you collect data for sexuality or gender identity, instead of tick boxes, leave a line or an open box so the person can write down themselves, because myself, I'm not just a gay man, I'm a gay demisexual man, so I can't tick that on the forms I fill in, so that gets it more open for discussion as well. And also providing comprehensive training on not just the identity and the needs of the LGBT plus community, but also the history. And like it was mentioned in other talks, that even though the community as a whole, each identity within this community has their own specific needs, and it might be different to, say, a gay man, for example, and just recognise that. And it's also supporting gender identity and expression, so respect preferred names and pronouns, and gender expression in care practices. And then also promotes LGBTQ plus community connection, so encouraging links with, say, the LGBT switchboards in Brighton, and they do dementia cafes and stuff like that, and online services, or United Communities, who have taken over the work of Opening Doors London. They're providing a lot more services as well. And yeah, and for me, part of this is a call of action. So basically advocate for inclusive policy, so pushing for national policies and wider that mandate LGBTQ plus inclusivity in dementia care standards, because at the moment it just seems to be tokenistic, because like for the Welsh Dementia Strategy and the training side of things from Social Care Wales, they mention about the LGBTQ plus community and training, nothing in the resources. So, and support the LGBTQ plus organisations, if you're from the UK, like Stonewall or the Switchboard LGBT Foundation, because they do have connections. You might be able to collaborate with those organisations and provide resources to make your services more inclusive. And also implementing comprehensive training, like we mentioned, because there is training available out there. But like in the United Kingdom, for example, it's all, we call it a postcode lottery, so it's mainly like places like London, Manchester. I'm from the rural area of Wales, there's nothing. So, but we are changing that, and hopefully we might be having our first LGBTQ plus Dementia and Ageing conference next year in Wales, and that's through networking through this event. So And then it's also about promoting visibility in all services, displaying the LGBTQ plus symbols or materials to signal that inclusivity. And also facilitate access to resources. So I know in care homes they have resources, but it's always aimed at, from what my experiences, is aimed at heterosexual couples and stuff like that. And then those resources can help those people, this community, to connect with local community support groups and services, and also include the community in development of resources and policy reform, and just not seeing them, and just seeing them as partners as well. And also challenging discrimination and stereotypes, so speaking up against the bias and advocate for equitable treatment in all care services or organisations. And then, just to sum it up really, so yeah, there is an emphasis on inclusivity for everyone in dementia care, and you can hear that through the talks today. And it's also about recognising the unique identities and experiences of everyone. And then also recognising the challenges, and also the specific challenges faced by the LGBTQ plus individuals, like the higher risk of socialisation, the discrimination, and trying to turn those around. And then understanding the importance of affirming identity, because supporting and affirming the identities in dementia care is crucial, and because it's preserving dignity, enhancing well-being, and fostering a sense of self. And we do ask for people to commit to best practices. So implementing best practices, there's loads of, resources online and organisations around who can help. And by committing to these best practices, it can significantly improve the care for the LGBTQ plus individuals. And there is a need for systematic change across the board in healthcare policies, dementia care policies and social care policies to ensure that LGBTQ plus individuals and in dementia is prioritised and practiced not just, say, in local areas, but nationally. And then, like I said, encouraging the community connections. They do provide vital support networks that can combat that isolation and enhance quality of life. And it's also that collective responsibility. It's not just members of the LGBT plus community who should be standing up for these rights. It should be everyone. And everyone has that role, from dementia care providers to policymakers, to ensure this equitable and compassionate care. Thank you.
Thank you very much. Thank you very much for your very impressive presentation. Please join us. And now it's time to listen to our last speaker, Emma McGlinchey from Ireland. She will talk us about inclusion of people with Down syndrome across the Alzheimer's disease continuum. Dr. Emma is an assistant professor in intellectual disability and a faculty member at the Global Brain Health Institute at Trinity College, Dublin. With a background in psychology, Dr. McGlinchey leads the Prevent Dementia project and is the site lead in Ireland for the European Down Syndrome Consortium. This project examines biomarkers for Alzheimer's disease in people with Down syndrome using a variety of methods, including neuroimaging, blood-based, and cognitive biomarkers. She works internationally to support people with Down syndrome and address the inequities faced by this population. For over a decade, Dr. Emma has worked to ensure that people with an intellectual disability are included in the research process as advisors at all stages. Thank you very much. Please, the floor is yours.
Thank you so much. Thank you so much for the introduction, and thank you for the invitation to speak today. I'm really delighted to have the opportunity to talk about the importance of including people with Down syndrome across the Alzheimer's disease continuum in research and care and policy. So I think over the last number of years, there is a growing awareness of the connection between Alzheimer's disease and Down syndrome, but there is still a lot of work to do in order to achieve equity. We still see a lot of disparities, particularly around access to healthcare, access to timely diagnosis, and that this has an impact on health outcomes, on assessment, on timely diagnosis, which then can impact quality post-diagnostic dementia care. And so I'm going to talk about some of these issues in the talk today, but because we're talking about intersectionality, I also want to think it's important to highlight the inequities and disparities we see within the Down syndrome population. So the Down syndrome population is a heterogeneous group who don't experience dementia in the same way. And so factors such as race, socioeconomic status, and region are going to impact the experience of people with Down syndrome and the health outcomes as well. So first, starting with the good news, is the increase in life expectancy that we've seen over the past number of decades for people with an intellectual disability. In the graph on the right, you can see the increase in life expectancy for people with Down syndrome, where in the 1930s, the average life expectancy was 9 years of age, and that increased dramatically with cardiac surgery in the 1960s having a dramatic impact, and that is now in the 60s. However, we do see that people with an intellectual disability are still dying approximately 20 years younger than their peers in the general population. And for people with Down syndrome, Alzheimer's disease is the cause of death for almost 80% of cases. So this is the primary driver that's limiting life expectancy for people with Down syndrome. So just to contextualize this relationship between Alzheimer's disease and Down syndrome that many of you may be familiar with, Down syndrome is caused by trisomy 21, or 3 copies of chromosome 21, and it's chromosome 21 that produces the amyloid precursor protein gene, or the APP gene. And so people with Down syndrome have an overexpression and overproduction of APP, which leads to those amyloid plaques and neurofibrillary tangles that we know as the hallmark of Alzheimer's disease. But beyond that, this was research by Juan Fertea and colleagues in Barcelona. We know that there's a predictable sequence of biomarker changes in people with Down syndrome that start decades before clinical presentation of dementia, and that this sequence of changes is strikingly similar to what we see in autosomal dominant Alzheimer's disease. And so more recently, Down syndrome is now considered a genetically determined form of Alzheimer's disease. And in the most recent revised criteria for diagnosis and staging of the Alzheimer's Association, Down syndrome is considered as stage 0 in Alzheimer's disease. And so I just want to take this moment to highlight the crucial and the real need to ensure that people with Down syndrome are included in clinical trials. I know Professor Matt Janicki spoke about this on the first day. This is a population who may benefit the most from disease-modifying agents, and up until now haven't been included in clinical trials, although this is changing. So moving from pathology to clinical diagnosis, this is data from a 20-year longitudinal study in Ireland that looked at age-specific risk for clinical dementia for people with Down syndrome, where by age 65, the risk of clinical dementia is 88% in people with Down syndrome, and that this increases to almost 100% as people live longer. In a more recent meta-analysis, the mean age of diagnosis for people with Down syndrome is 53.8 years, so much lower than we see in the general population. So while genetic factors are the primary driver for Alzheimer's disease in people with Down syndrome, we also need to consider modifiable risk factors and how these may impact the clinical presentation of dementia in this population. But as we're looking at the risk factors in the Lancet Commission, if we look at the prevalence of these risk factors within the Down syndrome population, we see that there's huge differences. So this data is taken from a longitudinal study in Ireland. There's a longitudinal study in the general population called the Irish Longitudinal Study on Aging, and we have an intellectual disability supplement to that study where we can compare the aging experience of people with an intellectual disability to that in the general population. And the data here is extracted just for those with Down syndrome. So if we look at, for example, education attainment, we see that the risk for people with Down syndrome is much higher. People with Down syndrome over the age of 45 in Ireland had very low levels of education. We would hope that this would change for the generation now, where people who were in their 50s now didn't have a right to education when they were growing up, so that will have changed. We also see that depression, the prevalence of depression is much higher for people with Down syndrome, and levels of physical inactivity are much higher. So these are areas where the risk for these modifiable lifestyle factors are increased for people with Down syndrome. On the other side, there are some areas where there may be protective factors. So vascular issues for people with Down syndrome are lower than we see in the general population. So things like hypertension, high cholesterol, we see a lower prevalence of people with Down syndrome. So this is something that may be protective. There's also lower alcohol and smoking. There are then other issues that we may conceptually think as different for people with an intellectual disability who may have been in receipt of lifelong care. So for example, living in a community group home or living in a residential setting. So here we may need to think about what is the mechanism by which social isolation impacts brain health. And if people are living within a community group home and surrounded by people, but maybe not making that active choice, does that mechanism work in the same way? Or are we looking more at the subjective experience of loneliness as opposed to the objective measurement of isolation? So we still see inequities in access to timely diagnosis for people with Down syndrome, and assessment is very complex in this population. So first of all, pre-existing lifelong intellectual disability can make it difficult to distinguish cognitive decline from that pre-existing level of intellectual disability. And because of this, the best practice guidelines are that everyone with Down syndrome will have a baseline screen by the age of 35, so that if at a later stage there is concern of cognitive decline, it's possible to measure against that own person's best level of functioning, because normative scores aren't relevant for this population because of the variance we see in pre-existing level of intellectual disability. This also means that standardized tests that are used for Alzheimer's disease aren't appropriate to this population. We'll see floor effects that's due to intellectual disability rather than due to cognitive decline. However, there are a number of valid tests that are used within this population. So, for example, the CAMDEX DS2 or the modified cued recall test. And these have shown the ability to discriminate from Alzheimer's dementia, from prodromal dementia and asymptomatic, and among people with a mild level of intellectual disability or a moderate level of intellectual disability. For people with a more severe, profound level of intellectual disability, there's a reliance on informant-based measures. As I said, there is still an inequity in access to assessment and diagnosis because there's a need for specialised services. So, for example, in Ireland in 2020, we established the National Intellectual Disability Memory Service, where people with an intellectual disability can now be referred to if there is any concern around cognitive decline. And as we know, that timely assessment is hugely critical in order to ensure that there's good quality post-diagnostic dementia care. And so moving on to post-diagnostic care, in Ireland there are fantastic guidelines for the general population that were published over the last number of years. And within these guidelines, there was a specific recommendation that there's a need to develop guidelines specifically for the intellectual disability population. And that's to take into account the lifelong differing experiences, differences in residential settings, and to ensure that level of intellectual disability is taken into account. And so with support from the Alzheimer's Society of Ireland and the Health Research Board in Ireland, we developed post-diagnostic dementia support guidelines for people with an intellectual disability, and these were just published a few months ago. So within these guidelines, there are 5 pillars of post-diagnostic support with 33 accompanying standards. And with all of these guidelines and standards, the person with intellectual disability and dementia is always at the centre. And we developed these guidelines in conjunction with experts working in the field of dementia, but also importantly, people with Down syndrome and intellectual disability living with dementia and their families to make sure that we understood their experience, what supports they were getting that were important, and what supports that they weren't getting important that they felt they needed. So this is just an example of what the guidelines looks like. So each pillar has a number of standards and guidelines. And then there's also processes that accompany each of these standards. And this was really important for us to ensure that the guidelines and the standards would be implementable and actionable. So throughout the guidelines, there are a number of links and a number of other resources that can support intellectual disability services in implementing the guidelines and ensuring that there is good quality care for people with intellectual disability living with dementia. So up until now, I've spoken about the disparities and the inequities that we see between the intellectual disability population and the Down syndrome population and that of the general population. But we know that there are also inequities within the Down syndrome population. So this is data, this is part of a meta-analysis, and this is data from CDC in the States that looked at differences in health outcomes and mortality for Black people with Down syndrome and white people with Down syndrome, and found that across all age groups, Black people with Down syndrome were dying younger than white people with Down syndrome, and that this difference was bigger than we see in the general population, so that they may be more vulnerable to these inequities. A more recent publication just in the last few months from Eric Rubenstein also looked at differences specifically related to dementia and age of dementia diagnosis. And they found that minoritized groups were at increased risk for dementia and had a dementia diagnosis at an earlier age than the white people with Down syndrome. I just go back to, I showed this graph at the start where we saw that increase in life expectancy for people with Down syndrome. This data is from Australia, and actually all of the data that's been presented has been either from the US and Europe. So there are large consortia working in the area of dementia and Down syndrome. There's the ABCDS consortium in the US and the Horizon 21 European Down Syndrome Consortium in Europe. And the reality is that the majority of data we have around Down syndrome and dementia comes from the global north, so it comes from the US and Europe. We know that there's approximately 6 million people in the world with Down syndrome, and that there's approximately 800,000 in the US and Europe, which means that the vast majority of people with Down syndrome are living outside of the US and Europe, but where we know very little about health trajectories, access to care, or any of the other issues that I've talked about so far. And so there is a real need to ensure that we include people with Down syndrome in the Global South and in other regions. I recently conducted a scoping review looking at Down syndrome research across Africa, and there was 131 studies that have been conducted, but the majority of these have been focused on children, with only 9 studies including adults with Down syndrome. There's very little epidemiological data, so we know very little around life expectancy, around health conditions and health comorbidities. And so this is a crucial gap that we need to understand so that people with Down syndrome across Africa and the Global South are not left behind. In the introduction, it was mentioned that I'm a faculty member at the Global Brain Health Institute. And the Global Brain Health Institute is an initiative between Trinity College Dublin and UCSF in San Francisco that is focused on addressing inequities in brain health, and particularly in underserved populations. This is a fellowship training program, and it provides unique opportunities to support this type of research across the Global South with a global network of fellows that work at community level. So there are currently 232 Atlantic Fellows at GBHI from 53 countries. And over the last year or year and a half, we've been working to support and develop Down syndrome research across Africa, and to ensure that this population is included. So I'm just going to finish with a quote from a colleague, Mei-Lin Yap. This is a woman who works with us in the Trinity Centre for Aging and Intellectual Disability with Down syndrome. And this is a small section of a speech she made at a Down syndrome and dementia conference a number of years ago, where she talked about the importance of her own voice in conversations around dementia. So I just want to finish with her words, where she said, "Like everybody here, I have dreams for the future. There are things that I want to do, and I know dementia might play a part of my life too. So when you start talking about dementia, I want to be included in that conversation. I want to be included in the conversation about my future. I want to be empowered so that I can choose how to reduce the risk of dementia." Thank you so much.